Faith-Forward Media. This is Healthcare Musings. I'm Dr. Hassaballa. Welcome everybody to Healthcare Musings. Happy to have you with me. All right, so now this is part 2 of sleep in the ICU. Last time we talked about the classic sleep deprivation experiments with rats, I think at the University of Chicago, where they totally sleep-deprived rats and found that they died within 30 days. Then when you sleep deprive rats, when you REM deprive rats, they die within 54 days. And then if you deprive high EEG amplitude sleep, I think that's slow wave sleep, they die within 66 days. So it takes it longer, but all of them died when you deprive all of the important stages of sleep. And I talked about how it's so important not to skimp on sleep, and you just can't. It's so important. It's good for mental health, brain health, body health, everything. So now we're going to go into the guidelines with respect to sleep in the ICU, and then what we need to do. So I am quoting from the SCCM guidelines for the pain sedation guidelines. They were published in 2018 and then updated in March of 2025. And so I'm just going to read from the recommendations here. It said that we suggest, and it's interesting, so we suggest not using aromatherapy, acupuncture, or music at night to improve sleep in critically ill adults. I've purposely excluded people on ventilators because they do have recommendations about what kind of medications to use with people on ventilators and different ventilator modes. We're not going to talk about this because there are a bunch of patients who are not intubated, who are not placed on ventilators, who get admitted to the ICU. For example, people with diabetic ketoacidosis get admitted to the ICU, and most of them, thank God, are not on ventilators. People with heart attacks get admitted to the ICU. People with strokes who get TNK are admitted to the ICU. People after vascular surgeries and some other kind of surgeries are admitted to the ICU. So there are a lot of people who are not intubated and sedated who get admitted to the intensive care unit where their sleep gets heart surgery patients, where their sleep gets affected significantly, right? And so those are the ones that I'm talking about. So then I think that's what we should focus on, is really trying to make their sleep as optimal as possible. So they don't suggest using aromatherapy, acupuncture, or music at night. That kind of makes sense, right? You want them to rest, right? You don't want to keep poking them or have music. Maybe music during the day, but at night, that totally makes sense. They do suggest using noise and light reduction strategies to improve sleep in critically ill adults. That's very important. In the old guidelines, they had no recommendation as far as melatonin, but in the new guidelines, they say we suggest administering melatonin over no melatonin in adult patients admitted to the ICU. With a low certainty of evidence, and the POEM CCM Substack went over that data in the study, and that they're kind of skeptical of the data, and everyone should subscribe. I'm a founding member. Everyone should subscribe to that Substack. It's fantastic. So they do recommend melatonin. That's important. They make no recommendation regarding the use of dexmedetomidine, which is a sedative, at night to improve sleep. They do not suggest using propofol in adults to improve sleep. That's inherent. I would not, unless you have someone monitoring the airway, you should never use propofol to help someone sleep. I think that's what killed Michael Jackson, which is the stupidest thing that doctor could have ever done, is to give him in a non-monitored area with a non-airway expert propofol to help Michael Jackson sleep. That was stupid, so stupid. I mean, I've had anesthesiologists give propofol before bronchoscopy procedures that I was going to do, and the patient had undiagnosed sleep apnea and turned blue, and he had to intubate him. So, okay, no one should do that. Stupid. And it's kind of common sense, but they put it in the guidelines. And they also suggest using sleep-promoting multi-component protocol in critical ill adults. So those are what the guidelines say. And so what should we do? Sometimes when you're in ICU, you have to have your vital signs taken every hour. It's super important. If you're in shock, some people who come in with septic shock are not intubated. They're awake. They're alert. They're responding and talking to us. We have to check their vital signs every hour. We have to, because we're titrating norepinephrine or epinephrine or vasopressin or dopamine or any number of vasoactive drugs. We have to follow their vital signs every hour. You're squeezing your arm every hour. You have an arterial line. The monitors are beeping. Sometimes you can't avoid that. At the same time, what about the patients who are not like that, who are not, don't have a balloon pump after a heart attack or not on vasopressors? We should try to promote their sleep. We should try to have quiet time at night, and we do it during the day too in our ICU, and it's made a big difference. Quiet time at night. Turn the lights off. I really give them melatonin, and 3 milligrams is a low dose, guys. I usually give either a minimum 5 to 10 milligrams of melatonin, but you have to kind of be careful of the timing. If you time melatonin wrong, it can worsen the circadian rhythm. You have to be careful. Give melatonin. I would avoid benzodiazepines. Unless you're on chronic benzos, I would avoid benzos. Those cause worse delirium. Lights down. If you can turn the monitor in the room off and still be monitored outside, what's wrong with that? I mean, we're watching there, and that way it doesn't beep in the room, it beeps outside. This is not for everybody. This is not for somebody in septic shock, on a ventilator, on a balloon pump, but and I don't like to use the word but, and if you can put the monitor on outside, why not? Don't let them beep all the time inside. Make sure that the IV poles. I mean, sometimes you can't. The patient will turn on their side. They'll bend their arm. That's what happened to me when I was in the hospital after my thyroid surgery. I kept bending my arm, and then it would block the IV. And then it would start beeping. Those IV pumps, the beep is loud on purpose. It's supposed to be so that the nurses and the staff can hear it, but it's sure disruptive. To try to minimize so that you minimize the IV beeping, and lights down and earmuffs. Why don't we put earplugs? Give patients earplugs and eye covers. I think a lot of hospitals have these sleep kits where they have eye covers and earplugs. We should do that for everybody who comes in like a DKA or heart attack that is okay, stable after a cardiac cath procedure. Quiet time, melatonin, putting the monitor outside and not inside the room. Maybe we don't have to vital them every hour. If they're not on vasoactive drugs, we don't have to have frequent vital signs. Maybe every 2 hours, every 3 hours, safely overnight. Labs. I have started ordering my labs at 6 a.m. in the ICU. A lot of places do it 4 a.m. or 3 a.m. That's so early in the morning. I know there are doctors who start their rounds early and they need to get in early and they want to know the lab results. But come on, 3 in the morning, you're waking somebody up in the middle of their sleep to get labs and poke them and it hurts. And why not later in the day? I walk in at 7. If the labs are drawn at 6, most of the time, by the time I get started and going, the labs are back, especially in the ICU because mostly they're stat. It's much more complicated and to do that on the floor, right? That's a different issue. And if I could do it, I would have all the labs at 6 o'clock. Imaging studies. Why do they have to be at 5 in the morning? Why do you have to get an x-ray every single day? If you don't have to get an x-ray every single day, don't do it. Why, if you have to get an x-ray frequently, say somebody has a pneumothorax and they have a chest tube, why does the chest tube have to be in? Why does the x-ray have to be at 3 in the morning, 4 in the morning? Make it 6 o'clock. So if you're not going to round until 8 or 9, then why bother your patient at 5 in the morning to make sure that the x-ray is done? You can, why not order the x-ray when you get there? As soon as you walk in to the unit, now, I'm only in the ICU. It's different for me. A lot of my colleagues, the ICU is one of several places, and they have to go to the OR. That I understand that. But you're in the ICU and you need an x-ray in the morning. Why do you have to get it at 6 in the morning and wake them up, or 5? As soon as you arrive, order the x-ray. You're right there. I don't think I've seen where an x-ray machine doesn't have the image right there, the screen in the machine. So why don't you just order it when you walk in? So then you can just get it real time and look at the x-ray right then. Let them sleep. Let them get rest. If I don't have to talk to the patient, I let them sleep. I'm there all day. I can always circle back and check in with them later. And I can't tell you how many patients appreciate that. They say, oh, bless you. Because I know how hard it is. When I'm walking in, a lot of them are sleeping. And if I don't have to talk to them at that very moment, I don't. I let them rest. I let them sleep. these are the kind of things that we should start systematizing and protocolizing in our ICUs to really help our patients sleep. I had a family member of a colleague get surgery in the ICU, and they started having hallucinations because they're not sleeping. And I'm sure sleep deprivation leads to delirium. I am 100% sure. And having delirium in the ICU is not a good thing. It is not a good thing. So whatever we can do, this is guideline recommended, not strong evidence. Some of it's self-evident, although that's not what we kind of practice. We don't want eminence-based medicine, but evidence-based medicine. At the same time, promoting sleep in the intensive care unit can only bring good to our patients and let them rest and recover. And we should do whatever we can and protocolize it and systematize it in our ICUs so that our patients can get the rest that they need and deserve. Thanks so much, guys, for your time and attention. And until next time, Hashem Hassaballa signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.